So good afternoon, everyone, once again. My name is Professor Bianca Bridgenath, and I am the Director of Social Gerontology at the National Aging Research Institute, or NARI. Welcome to our online seminars in Aging program. I'd like to begin our session today by acknowledging the traditional owners of the lands on which each of us are meeting. For me, that is the Wurundjeri Woi-wurrung people. I would also like to acknowledge the traditional owners of the lands and waters across Australia. And I pay my respects to elders past and present, and to all Aboriginal and Torres Strait Islander people, including members of the Stolen generation. So first, a little housekeeping. So at the conclusion of the talk today, we will have time for Q&A. If you have any questions, you can submit them throughout the seminar using the chat function, which can be opened using the chat tab at the bottom of your screen. Today's seminar is also being recorded and uploaded onto our website in a few days. So keep that in mind if you turn on your video to ask a question, that your image might be included in the final recording. I'm really delighted and excited today to be welcoming distinguished Professor Patsy Yates AM. Patsy is the Executive Dean, Faculty of Health at Queensland University of Technology. She has researched and published extensively on health service and workforce reform and innovations in supportive care in cancer and palliative care. And she is currently an NHRMC Investigator Fellow studying palliative care services in aged care settings. She's a past president of Palliative Care Australia. And today she's going to be talking to us about strengthening palliative care services for older people. So welcome, Patsy. We're delighted to have you, and over to you.
Thank you, Bianca. It is wonderful to be here to talk at this seminar with NARI, a really important organisation, which I admire and respect the work that your organisation does. So I'll start by also acknowledging the traditional owners of the lands on where I'm sitting today. That's the people of the Turrbal and Yagara nations, and pay respects to their elders, past, present, and emerging. I'll just share my screen. I'm hoping you can all see that. So what I'd like to just talk about today is really focus mostly on a very large project that I'm involved with, co-leading with some colleagues of mine from Flinders University and UTS. That really, it's funded by the Department of Health and Ageing, and it's enabled us to explore over a number of years a range of different strategies for integrating and embedding quality end-of-life care across both residential and community settings for older people. So I'm going to talk today a little bit about the components of that project, but focus specifically on one component, which is really about strengthening the links between specialist palliative care services and aged care providers in order to improve outcomes, end-of-life care outcomes. So as I said, this project is called End of Life Directions in Aged Care, and it's been funded by the Department of Health and Ageing, and it's a free online resource for aged care workers and healthcare professionals caring for older people at end of life. And it's got three specific aims, and that is about building palliative care and advanced care planning knowledge, skills and linkages in aged and primary care. It's about promoting lasting change at individual service and system level. So when I show the different strategies we're using, you'll see that they're focused at all of those levels in aged and primary care. And really aiming, of course, ultimately to improve those sort of those harder outcomes around reducing avoidable hospital admissions at end of life and shortening stays in acute care settings for older people at end of life where that's preferred, and also including improving quality of care for people supported. And later on, when I show a bit of data, I'll show you some of the measures that we're using to assess that. And just acknowledge my collaborators in this large consortium for this national project. And as I said, QUT, Flinders and UTS are the co-leads, but we are a strong consortium which involves Palliative Care Australia, ACPA, AHHA and Catholic Health Australia, and we've been working together for the last 6 years on this project, and it's been a fabulous collaboration between academic and non-government organisations, and we have a very influential advisory group that is led by a number of consumer organisations as well, that help us to really sort of drive the direction of this project. As I said, 4 key program objectives, really about providing specialist palliative care and advanced care planning guidance to aged care providers and general practitioners, about improving linkages between the range of different services involved in providing end-of-life care, about improving the palliative care skills and advanced care planning expertise of the range of different care providers in aged care, and ultimately improving that quality of care, as I said. So they're 4 multi-component, which is why the approach that we're taking really includes multiple different levels of intervention. And I know this particular circle is not that easy to read, but I included it because we really wanted to sort of highlight the different levels at which we're working. So if we start, for example, here, at the core of ELDAC is what we call our information and advisory service, and that's really our knowledge hub. We've got an extensive website where we have a range of toolkits and actionable resources that people from various different sectors and various different organisations can access to provide that information and advice around delivering quality palliative care and advanced care planning. We also have what we call a technology solutions stream, and that technology solutions stream is where we've been experimenting with different sort of things like developing digital dashboards or developing technology-based tools, which might be, for example, audits that might be integrated into routine practice, as well as developing things like we've got an online self-care room for people as other examples, and some apps that we've developed for care workers. Workforce capability is another major area at which we work. So we've developed an app which is a searchable sort of directory of different educational opportunities which people can navigate their way through to find particular learning that might be relevant to them at that particular time, as well as search for perhaps the level at which you're working and the setting at which you're working, or the population that you're working with. But in addition, we're sort of developing some capability statements and some resources to help build workforce capability. Service partnerships, and that's the piece I'm going to talk mostly about today. And here we're sort of working one-on-one with different service providers to really work on with a 12-month or up to 12 months, between 9 and 12 months, at a facilitated process of really embedding quality end-of-life care at the organisational level, and mostly doing that in collaboration with our PHNs or primary healthcare networks, or GPs, primary healthcare services, to support that work, as well as specialist services. And lastly, what we call our system capability. And here we're doing a whole lot of things like community awareness campaigns. We've got a My Care Matters campaign where we're really trying to sort of promote an understanding and awareness of palliative care, as well as doing some other sort of policy and evidence guidance from time to time that we work on. So it's a multiple different levels of program that we're working on, and it's also based around what we call our framework for care, which considers palliative care, I suppose, across 8 different domains that obviously you don't go in a linear way, but we've called this model out to reflect that we're actually looking at palliative care not just being the last few days of life, but really focusing on advanced care planning. How do we recognise end of life? Because that's really critical to actually implementing the range of interventions. How do we assess palliative care needs, providing palliative care, working together, responding to deterioration, managing that dying process, and bereavement. So the model and the areas which we work really are based around the notion that we've got to get all of these pieces right if we're going to have a quality end-of-life care experience. So as I said, today I'm going to talk a bit about that service partnerships and just provide some examples and some data of the outcomes that we've achieved by working with services to improve end-of-life care. So essentially we call this our Linkages program. And it's supported by, we've got a few, what we call our ELDAC facilitators, and they're experienced nurses or allied health professionals who will work one-on-one to provide a facilitated experience for the teams within within an organisation, whether it be a residential facility or a community aged care provider, to actually help them build partnerships and service improvements to really achieve that integrated care and a multidisciplinary approach to care. And participants are stepped through this program that's tailored to their different needs. It's a diverse range of services who've been part of this program to date, where we essentially look at doing a range of different audits and assessments around capability and gaps, and we work with them to set in place the standard sort of quality improvement approaches through a PDSA sort of cycle. We work both at the organisation level, but also with individual staff to provide education, training, and integrate policies and procedures at that organisation level. And we help assist them to use that data to drive further improvements. So essentially we work with them through this journey. It's very much around the services, though, identifying their priorities and us just using the frameworks and using the range of resources that we've built through ELDAC to help them achieve their priorities and their goals. This is based on a whole range of different evidence reviews that we've done about how to improve end-of-life care in aged care settings over time. We're just updating this review. This was a review we did a couple of years ago, where we particularly focused at that time about how do you build interorganisational linkages to achieve good outcomes, noting that good end-of-life care often requires multiple service providers to really come together. And so we really focused on what those linkage strategies were. We're actually just updating this to be a broader sort of review at this point in time. But at the time when we did this review, we identified that there were 7 particular strategies that we wanted organisations to focus on through their service improvement. And that was, they related to things like role clarification, developing communication pathways, looking at how we can have multidisciplinary team structures and processes, sometimes formalised agreements and plans across organisations, designated linkage workers, knowledge exchange and upskilling, and continuous quality improvement. So a lot of these strategies we use in service improvement were often based around these types of strategies, but they did include a range of other things as well. And the process that the services go through is we have like an onboarding process where once we openly advertise for services who wish to participate in this program, and we are often overwhelmed with the expressions of interest. There is high demand for and enthusiasm for improving end-of-life care in many of our aged care services. And so we have a process where we sort of assess their readiness, their ability to sort of participate and achieve, because it is quite an intensive program of work that we work with these services at quite a time where they are under a lot of other pressures that they have in delivering their services these days. So we have an onboarding where we induct them and we undertake some audits at that initial phase where we do service mappings, we link, we do gap analyses, and we collect some baseline data, and I'll show you some of that, which we use to build an action plan. We work with them to identify what their priorities are. We then implement that action plan. We help them to and support them through a range of different, by linking them to different resources, different other services, and help build sort of team-based approaches. And that might be champions, it might be change teams, it might be whatever is suited to that organisation to help them achieve this improvement, and that is sustainable. And then we have our post-implementation where we again do follow-up audits to see what change has been made. We integrate a whole range of sort of sustainability measures where we help them have another plan which focuses on how they're going to sustain the change. And we link them in with a network and a community of practice, in a sense, of other providers who have participated in these services. So I'm now just going to take you through a little bit of some of the outcomes and some of the data for the different, for the time that we've been working through this project, just to give you a snapshot of the types of things that we're measuring and where we're seeing change. So to date, we have had a total of 297 aged care services enrolled in over this 6 years, and we had a pre-program which was called Decision Assist before we moved to ELDAC, and so we've had 297 aged care services. And in total, there's been at least one aged care service enrolled in the program from each of the 31 PHNs. So we've really tried to mobilise the network of services that really need to come together to provide the capacity and capability for aged care services to deliver good quality end-of-life care. And so we're really pleased that we've done a lot of work at linking in with the PHNs to see how they can support different aged care providers. So we've had, early phases, they were like pilot phases where we were learning about, what we needed to do and building our systems and processes, but we've ramped up quite considerably the numbers in each of our different phases. And over this last 3 years, we had an extension of some funding to actually, because we had such a wait list for programs, that we got some funding to deliver another 90 services, support for another 90 services. What's also great to see for all of these services, so the 297 location, we've got a good distribution around the country. And in particular, we've got obviously over half in major cities of Australia, we've got a number of services who really are linked in, which are from inner regional and outer regional, and even some from our remote areas of Australia. We've also worked with services who specifically provide services for Aboriginal and Torres Strait Islander people, or for culturally and linguistically diverse populations, or for LGBTQIs plus groups. And we've also worked with services with Homeless Service who provides palliative care for homeless populations. So a good broad range of services who we have recruited. And of those 297, 78% of them are residential and 22% have been home care services. And in total, that's combined of over 35,000 beds or packages. So it's quite a good reach, although we know that we're still, continuing to ramp up to scale this up more broadly. So just to give you a bit of an idea, and I suppose so those were the early pilot phases, but just showing you that these are the numbers of packages and beds in the services that we are working with. So we're continuing to grow the reach of this program. So our outcome measures that we use 5 key audit types at pre-implementation and post-implementation. One of them is an organisational audit, where we really assess organisational readiness to deliver palliative care. We have a Linkages Strategies audit, where we're assessing how well the partnerships are going with other providers in delivering palliative care. We have the partnership tool. We have what we call an after-death audit, where we ask the services to, we have a number of quality indicators of end-of-life care, and to assess the 5 most recent deaths in their organisation against this audit, to determine, whether these indicators were achieved. And we have a personal learning assessment tool, which is used by the staff within the organisations. So as I said, they do these tools pre and post, and we have a range of other process measures, of course, that we are using. So of the services, and we've just got the 207 because we don't have post data on some of those most recent services we've enrolled to date. But to give you an idea of the sorts of things that they've done to try and improve these outcomes, a big focus from all of the services is that they do want more knowledge exchange and upskilling. It's one of the big things that they come to us and they say, we need education. And so it's a really critical part, although we try and sort of help them think about what other system level things that they need to add so that education is sustainable. And that's where we see that many of the organisations implement communication pathways, role clarity, continuous improvement processes, and some, about a third, have also implemented designated linkage workers as part of their strategy to improve. So you see a broad range of different things, in addition to a range of things like policy development, consumer engagement, a whole range of different things that services do on top of this, which I haven't reported here, but we include in our process measures of other strategies that are used to achieve improved outcomes. So this is just a snapshot of some data from what's measured on the personal learning assessment. So this is where we ask staff participating in the program and post to assess, to report their knowledge. We did change the tool from the pilot phase to this most recent phase. So I'm just going to focus. Overall, you can see that there's improvements pre and post on whatever measure we use. But if we just look at this most recent data, which was where we've got the larger numbers, you'll see that we ask them to rate how much they know. And this in particular was an item about their self-reported knowledge of advanced care planning, pre and the mean score post. And so we'll see that knowing a small amount to knowing a moderate amount, in both these two most recent phases, we've noted some improvement in their self-reported knowledge of advanced care planning. Similarly, this is a broad item about self-reported knowledge of end-of-life care planning. And again, using the same sort of scale in this and personal learning assessment tool, we see some improvements for staff overall in that measure from their mean scores there. Moving to, and as I said, I've just selected a snapshot of a couple of examples for today's purposes, but this is a measure now of our after-death audit. And as I said, this is an audit of some key indicators of quality palliative care, and that we get them to assess the 5 most recent deaths in their organisations. So you'll see perhaps here, and again, I'll just look at the phases where we've had the largest number of services, and you'll see that this was a measure in an indicator, which is that clients have a palliative care or team conference, how many of them that was happening pre-implementation and how many post-implementation. So again, we see some improvements pre and post-implementation, that more services are trying to implement a case or a team conference about the resident or client who is dying. This is from the after-death audit as well, and this one is a measure of a documented advanced care plan pre and post-implementation. And you'll see that advanced care plans have had a lot of promotion in recent years, both in residential and community, but still, despite that, we've only got 65% of services in these most recent phases that actually have got a documented advanced care plan for people who have died. Remember, these are the 5 most recent deaths. We see some improvements in the post, but we still believe that that's something which we really need to increase the number of people who are having that advanced care planning. And so we're trying to develop more programs of support to assist and policy and consistent policies and advice around how that can be integrated within their systems. This one's a measure of the number of clients or residents who were commenced on an end-of-life care pathway or plan pre-implementation and post-implementation. And again, you'll see that some improvements overall in the 2 most recent phases. We again would like to see more that reaching even higher, but we're learning a lot about how we can support staff with standardized processes and tools that will assist them to do this easily. So that was some of the after-death audit measures. Some of the process measures, though, and some of the things that we've assessed in terms of how do we support staff to sort of translate some of the learnings that we've had from this program, and that we're continuing to build this community of practice, and we've now got models which we're experimenting with which is not just about a one facilitator with one service, but actually having groups of services. So we've got like a mentor model where we have a range of a group of services in a region. So in one region in particular, in regional New South Wales, recently we had 13 services that were mentored and supported with the PHN to actually work together to sort of share learnings. And so we're building a suite of resources around tools. We've developed what are some common tools. One of the most recent things, we had a showcase in Canberra where we had about 50 services who participated deliver either posters or presentations around what they did to achieve change in their organisation. And we've used that to develop, for example, a repository of tools that they were using, and also to do some, we're in the process of working out how we might do some evidence reviews to inform the basis of some of those tools that are being used and strategies being used in practice. We've got alumni webinars. We hold regular webinars with the services and for knowledge sharing, and we've published a series of case study booklets and videos, etc. As I said, we've had these workshops and forums and showcase events, which are just fabulous events where, we have, the care workers getting up and presenting the difference that it's made to their work and to their organisation by participating and really driving forward improvements, but also reflecting on some of the barriers and challenges, which is the ongoing learning that we need to do to continue to bring about this sustainable change. We've got our website, and we're continuing to refine our tools and present at a range of different sort of settings. And here's just a snapshot of some of the feedback that we've had from some of our qualitative interviews of staff who've participated. And here's an example of some themes which really relate to the sort of changes in practice. And as one participant talked about, the program has provided the opportunity to start an internal journey of evaluation and understanding of their service provision and relationships with other key stakeholders who support us and help us ensure that our residents receive good quality care. Another participant who talked about we've implemented a learning culture around end-of-life conversations and care, and we're continuing with the after-death audits and sharing our learnings from each conversation. And the third example there was through the ELDAC Working Together program, we've been able to implement strong guidelines, policies and principles with a strong focus from our ELDAC champion and improved communication processes for our families, residents and staff. Here's some examples of outcomes that participants reported. So staff being much more aware when we commence the end-of-life pathway, what that means. And I think, secondly, another participant talked about, I think the greatest revelation has been for all involved in the ELDAC Working Together program is the realisation that a good palliative care experience starts long before the process of dying begins, that it's about living just as much, if not more, than about dying. I know for staff, the experience has not only had impact on their work practice, but also on their personal lives. And other examples just around the themes in our interviews about what is it about this approach that seems to be most effective. And it talks about, participants have talked about things that collaboration with the facilitator has been a richly rewarding opportunity from an organisational perspective and a unique growth experience at each home. Enhancing the linkages between the program's best practice information measures ensures registered nurses and medical practitioners are able to access relevant and up-to-date information. And secondly, another participant talked about the huge amount of support of our ELDAC facilitator has helped us to achieve our goals. In the beginning, we worked together. We were able to make positive change in our palliative and end-of-life care. And the program has given us a good sense of purpose and meaning to our work. It's not an end, we're just getting started. So I think that the examples of our facilitation and our tools and our processes have been really key themes. I think, I've thought about, we talk a lot about, a model as, do you require someone as a facilitator, and we're, again, constantly evolving and refining the model so that I think very early on in the early stage, it was very hands-on as we were learning how to work with services, but we're really trying much more to see this as enabling and supporting, not really that the facilitator doesn't have a role of doing, and really trying to make and to build these other networks, communities of practice that actually where there's learning from each other. So the key lessons from this ELDAC, and particularly this Service Partnerships or Linkages program, is that, look, when we do our assessments, there's significant gaps in key indicators of quality advanced care planning and palliative care in aged care settings. We know they exist. We know there's significant gaps, and that there are major barriers to delivering quality of end-of-life care. And we know that, one of the great success factors of this program is we've been fortunate that we've taken a really very flexible and adaptive approach, recognising the challenges that the aged care sector is under. And even through COVID, we were able to continue this model, and services really pushed through with the support by us being flexible and adjusting. And obviously with changes in workforce that have occurred, workforce shortages, we've been able to sort of adapt plans and support them, looking at the strengths of that exist in the service, so that we use those to overcome their barriers. There's substantial interest in improving the quality of end-of-life care for older people. We are just overwhelmed by the passion that the people bring to this program, that building linkages across care settings can achieve improvements of care, experience and outcomes. And that while that's hard, because many of these services are often funded by different organisations, got different, communication strategies, different sort of governance structures, our observations of the way in which people are able to navigate those barriers and challenges are extraordinary, despite the fact that sometimes the system gets in the way, how people are actually able to overcome those system barriers. And that our strategies, which draw on evidence-based approaches to organisational and practice change, we believe really can achieve significant improvements. So thank you very much for the opportunity. And I just want to thank all of the people who've participated in the ELDAC Linkages program, and acknowledge the Australian Government Department of Health and Aged Care for our funding. And just leave with the last slide, which there's easy to find, hopefully, plenty of information about the ELDAC program on our website. So I'll stop there, and I'm happy to take any questions or comments. Thank you.
Thank you so much for that tour de force, I think, in many ways, Patsy. That was really comprehensive. I've got lots of questions, and I can see lots of applause coming through as well. I might take the chair's prerogative while people are using the time to gather their thoughts and frame their questions, to sneak in a few of my own. The Royal Commission has had major impact in terms of the kind of recommendations it's made around end-of-life care. And at the same time, it has triggered a huge suite of reform work in the sector. And so my first question to you is, has the Royal Commission and its kind of recommendations been an amplifier or a hindrance to the delivery of end-of-life care for older people?
I think that the Royal Commission, as well as just in the community more broadly, the awareness or the importance of end-of-life care is much more prominent than what it was, what it has been 10 years ago. People just expect that much more, that we get that part of a person's life better than what we have in the past. So I think that community awareness and community understanding has enabled that, and the Royal Commission really did amplify that. I think the reform process that's underway at the moment, again, we're trying to actually, to use that as an enabler and a strategy. So we're actually, and one of the things that we're doing at the moment is looking at all of our toolkits and all of our audits and things like that, to actually adapt them so that people can see how they easily map to the expectations that a care provider has to meet. Both from a client, resident, family perspective, as well as from, you know, an accreditation perspective, a regulator perspective. We're trying to sort of show how by doing this is actually really going to help you really achieve the standards that's expected by all of those groups. So I think it actually has helped. Having said that, though, without a doubt, the sector is under extraordinary pressure, and you know, we have had to adjust and adapt and accommodate that, but hopefully by bringing people in and valuing their work, that's actually helping them through that really extraordinary time of pressure as well.
Thanks for that question and the answer. Just to remind the audience that you're welcome to pop your questions in the chat, and or you can put your video on and directly ask your question as well. Those options are available for those who want to do it. I can see Joan's put her video on first. So Joan, you get to go first, and then after that, Barbara, if that's okay with you.
Thank you, Patsy. That was really, really impressive. I guess two thoughts. One, I was interested in perhaps the extent to which you think that model or that approach would work for other issues in the residential aged care sector. But secondly, one of the things that comes up that you'd be aware of is that the need to avoid disempowering staff by offering the service. And so sometimes when we go in and try and resolve or support the sector to deal with a problem that they lack the knowledge and skills in, we inadvertently they look to us to provide them with that support ongoingly. How did you deal with that in the ELDAC program?
Yeah, that's a really good question. I think we the whole model is based upon we come in as an intervention, and that it is about, but we work with people over time. They need to drive the program. So part of actually, and I think it may be part of the success, and it's one of the limitations, is that we're probably really only working with services who actually really have the commitment to really drive and take forward, because the expectation is we are not the experts, they are the experts. We provide them with the knowledge and skills and empower them to build their improvement plans, and they need to implement the strategies. And our facilitators, we have a specific time frame that we exit formally, but we still link them in with a community of practice. But it's part of, I think, again, our learnings have been really drawing on that richness of experience and passion and commitment that the staff have, and using that to sort of enable, I think. So, and your first question about, do I think this works? I actually think that, you know, some of these practices, some of the strategies we're using are really just consistent change processes which are using strengths-based approaches, and I do think that they would work. I think that the bit that we're actually doing a bit of a review at the moment of what are some of the enablers to, because one of the biggest barriers is system barriers. We can't do that because, you know, that system is funded by somebody else, or they're not allowed to share their records, or they're not allowed. And it's extraordinary how, when, again, you empower people and actually help them to get the right level of engagement, how you can actually overcome those. And so we're hoping that by actually sort of working at those multiple levels too, that it's going to be a sustainable change. But yes, I do think that the sort of strategies we're using are not necessarily novel in many ways. It's actually things that, you know, just a good change processes and service improvement processes.
Thank you.
Thanks for that. Barbara? We can't hear you, Barbara. Did you have a question?
Is that working now?
Yes, that is.
Oh, good. Patsy, I'm wondering how you define advanced care planning for this study.
Yeah.
What documents you would include in that?
Yeah. So we define it fairly broadly. Is that there is a documented process, and generally we link people to. So we've got, as part of ELDAC, we've built an end of life legal toolkit, where we actually have got a range of different resources that might be jurisdiction-specific resources. So we refer people to the sorts of resources that might help them. But essentially, though, if an organisation has a policy or a process, we accept that policy or process, but also try and, as part of our, providing them with further information about how to improve that, we link them in with other resources. So we do take a very broad definition, Barbara.
So that would include documents completed by a family member, even though they're not really advanced care plans?
Actually, no, that's a good question. We would, it's got to be sort of something that's it's a formal sort of document within an organisation, some sort of formal document that's an organisational level. Yeah.
Okay, so the organisation defines what an advanced care plan is rather than you.
Yeah.
Okay.
No, and I think this is part of one of the challenges that we've got in this space is that there is still, as you're quite right, Barbara, such broad understandings of what advanced care planning is. And so I suppose what we've tried to do, though, is at least sort of move people in the direction of at least beginning conversations and having something at that organisational level that is evidence that there has been some attempt to record preferences and wishes for end-of-life care. But it's a constant journey. It's a constant journey.
Mm. Okay. So goals of care would fit that very nicely. Yeah.
Yes. Yeah.
Okay.
Thank you.
Thanks.
No worries, Barbara. I thought I saw another hand up there. Did anybody else want to ask a question? Yep. Joan, and I can see Margaret's put her camera on as well. So maybe we'll get Margaret to go first and then we'll come back to you, Joan.
Not necessarily a question, it's more a concern wanting to raise. So my work, I'm an ACAT assessor or an ACAT clinician. I'm an OT as well by training. One of our biggest concerns from the palliative cohort that we see is really the way the system is set up for our palliative clients in the community, because the way the federal government outlines what constitutes a high priority on a home care package national queue is actually not on medical grounds. It's more around carer crisis, carer sustainability, at risk of going into residential care without services in place. So that's one concern, given that, we might see someone who is palliative and at the time the family is saying to us, we're coping quite well. The other concern is that even if they do qualify for a high priority level home care package, depending on where the funding sits with home care packages, they could be waiting a minimum of a month to get the funding allocated to them. And they may not have that amount of time and capacity to be able to wait that length of time to start getting a home care package in place. So from a community-based palliative point of view, it's really quite difficult.
Yeah. Really important observations, Margaret. We are doing a sub-study at the moment. It's what we're calling our home care study, partly because, I think, the evidence, there's a really good growing evidence base around palliative care in residential care settings, and how we're also much more easily able to do the regular assessments to really try and upstream identify, recognise dying and commence planning early, and mobilise people to actually respond to that. But in home care, the pathways are so much more diverse and really not defined. So we're actually doing a sub-piece. Deb Parker's leading is one of our co-leads, looking at just exactly understanding what those pathways are at end of life in home care, because I think if we understand them a little bit more, we might be able to sort of perhaps look at, where are the triggers? How can we actually more easily recognise dying so that we implement it? Because you're quite right, it's usually because oftentimes recognising dying is really the last few days or weeks of life, and you can't wait 4 weeks. It's an interesting observation, Margaret.
Yeah, no, you absolutely can't. And certainly in the location I work in, what palliative care services are available is limited. There's a bit of nursing, a bit of spiritual support, a bit of allied health, but it's not equivalent to a package of care. And so it is a bit of a gap in the community sort of arrangement, unfortunately.
Yeah, no, it is.
Thanks for that, Margaret. Joan, one more question for you.
There's no other questions. This is about dignity and the role that resident dignity plays in all of this. So in my research, I found that staff had very specific understandings about and commitment to protecting the dignity of residents with incontinence, I'm talking about. And then in the literature on dignity, of course, it comes up very strongly in relation to people with palliative care needs, people who are dying. I wondered and so in my work, I'm drawing on that driving factor, around education. To what extent does your program draw on, for instance, the work of Chalkanoff and reducing distress associated with dignity? Did you find dignity to be an important factor in this?
Look, in many, many different ways, because obviously, as you said, there's so many different factors that can be dignity enhancing or dignity compromising, isn't there? And I think so through our we've got this toolkit which actually really draws on the range of different practices that can help improve quality of life. And we probably don't necessarily, and now that I'm thinking about it, doesn't necessarily draw on a particular dignity framework, but obviously it's aimed at improving quality of life, and dignity is such a critical part of that, isn't it? So, but we do take a very holistic approach in our toolkits, which really tries to encourage that sort of thought that, and our assessment of needs, that there's many, many different factors that can actually compromise that quality of life at end of life. And you need to actually understand and assess and act on all of those as appropriate. So that's the sort of holistic approach that we would take.
Thank you.
Okay, we've got a question from Valerie, and then after that, we've got a comment or a question also from Riteshni. So Valerie first, and then Riteshni, and then we might have to wrap it up after that.
Yeah, thank you, Patsy. That was quite amazing. My question is, I'm actually one of the project officer for the comprehensive palliative care in aged care measure. That it's am I on mute? No, can you hear me?
Sorry, someone just came in the room. Apologies. Go for it. Sorry.
Sorry, I thought maybe you were not hearing me. And basically, I just want to know, have you had some of those project officer, approaching you? How can we actually work collaboratively rather than just duplicate? There's so many programs out there saying the same thing in a different way, which is, I think, really overwhelming for the sector. So how can we work together?
Yeah, look, I could not agree more, Valerie. And I think, we're part of one program that's funded by the Department of Health, but there are many, many others that are all, as you say, trying to do good work, everyone. And so we try very hard to sort of really do that service mapping at the beginning and really understand with the service that we're working with, who's in the local PHN. Have we had a conversation? We bring them to the table and we have these sort of joint, usually our goal is to bring a bunch of people together to have like a facilitated workshop at the beginning. But in terms of other projects, we're very well aware, we've got good line of sight with the other national palliative care funded projects, some aged care funded projects. We try and keep aside of some of the state and territory, but it's very hard to keep awareness of all of them. So, we really, part of our approach is to actually drawing on all of that, bringing everyone together to sort of and see how we can complement and work together. So Valerie, with your program, we'd be really pleased if you reached out to us, and it'd be great to know more about it and how we can actually when we're working in different regions, as I said, that's our one of our main strategies is working with everyone. Let's do a service map. Do you know what these providers are? We try and work with our engagement strategy at jurisdictional level, because there's so many different things happening at jurisdictional level. But, it's still so hard because we've got palliative care funded through one part, aged care funded through another, primary care, it's our wonderful Australian health and aged care system.
Thank you. I'm glad that we all agree. We just need to find it.
Please do reach out, Valerie. I'd be keen
I
to.
will, definitely. Thank you.
Terrific. Thank you for that, Valerie. We've also got a question from Riteshni.
Hi all. Thank you so much, Patsy, for sharing your knowledge with us. I work with Western Sydney in Community Specialist Palliative Care Service. At the moment, I'm at work, so I'm apologizing in advance. I'm at work, so I would have missed the information on this question I'm going to ask. So in our service, we do have lots of palliative care patients of all age groups, and usually with chronic and complex concerns who have got a poor prognosis of, I would say, less than 3 to 6 months, and they do not have any packages. So usually with chronic and complex, usually because they had these issues, so they do have some sort of arrangements with family or something. However, when there's some other elderly in population who all of it had cancer, and now they have less life, like 3 to 6 months, and they did not have any arrangements, no packages in place. Their wishes to die at home and remain independent, dignified for their end of life. And unfortunately, when their mobility declines, they're usually not able to go into palliative care unit because it's a short-term admission. And then unfortunately, we do have to transition them into aged care, where we know they're not so happy. We do have like some services in community available, like end of life care package, but unfortunately it is not 24-hour service. So in these situations, is there any suggestions, anything available for those ones? Because with the package, our social workers are great in helping them out with the packages, but unfortunately that takes months or longer weeks than short days.
Yeah, thank you, Riteshni. I think that's a similar question, I think, to what Margaret was raising before, really, around how, particularly in the home care space, our funding mechanisms have not really caught up with the complexity of care and the rapid way in which we need to respond. So I don't have any easy answers to that, but I think we've got to keep sort of, I suppose it's some of the advocacy piece, and as we learn more about the complexity of those pathways, to really try and drive forward some of the policy change and the funding change that we need to. But thank you for raising it. But I wish I had an easy answer to sort of solve that problem. But it's your experience is not unique, I think, than what we're observing in home care.
Okay, I might have to close the Q&A at this point, just in the interest of time. But as you can see, Patsy, you've stimulated a very vigorous discussion and lots of Q&A, so thank you for that. And I will ask all of you to please join me in thanking Patsy with your clap reactions. It's a poor substitute for a true applause, but it's what we do in our online Zoom world. The other thing I just wanted to alert all of you to is that we have a significant number of events coming up as part of the NARI education program. So first of all, next month, we will have Associate Professor Catherine Ellis presenting on the EXCEL study, a physical activity intervention for individuals with cognitive concerns and mental health symptoms. And that will be on Tuesday, the 10th of October at 12 p.m. However, if you are very inspired by today's talk, and I'm sure we all are, and you would like to come along to a few more NARI events quicker than that, we've got one happening at the end of this week and then one happening next week as well. So at the end of this week, on Friday, the 15th of September, we will have the 2023 NARI Annual Summit, which the theme is Menopause and Beyond. And we'll be looking at the issues faced by women as they progress through menopause and beyond, and how age and gender intersect with other social determinants to impact older women's health and well-being. Registrations are still available, and do visit our website for more detail. In addition to that, we also have a visiting scholar from Monash, Malaysia, Dr. Andrian Liam, and he'll be presenting next Tuesday, the 19th of September, in a special seminar with more details to come. And we'll put that information on our website as well, and send around a sort of topic and bio once he's got that to us, to our mailing subscribers as well. So plenty of things in the mix. But in the meantime, I do thank you all very much for joining us today, and wish you a safe and happy afternoon. And if you're in Melbourne, enjoy this rare and lovely sunshine. And if you're in other parts of the country, we're jealous, but wish you good sunshine and health. All right. All the best, everybody. Bye-bye.